Assalamu alaikum. Assalamu alaikum, everyone. Can I kindly request to take seats so we can timely start the next session? So next session is on pediatric oncocritical care medicine. And I would like to invite our first speaker, Dr. Ikramul Haq. Dr. Ikramul Haq is the Chief Division Chief of the Pediatric Critical Care at Sidra Medicine, Doha, Qatar. He has graduated from Dow Medical College and followed by his residency and fellowship in USA. He is American board certified in general pediatrics and pediatric critical care medicine, and he's worked at University of Texas Health in Houston, USA. His active research focuses on cardiopulmonary resuscitation, therapeutic hypothermia, ischemic neurological injury, and relationship between the pediatric asthma and obesities. He received multiple peer review grants and has numerous publication in a reputable resuscitation journals. Thank you, Dr. Ikramul Haq. Welcome to SKM.
Assalamu alaikum, everyone. It's happy to be in Lahore, and it's my first time at Shaukat Khanum Symposium. And so far, I'm enjoying it very well. Thank you for inviting me. I think based on the session this morning, we're going to switch gears a little bit and try to do something which is called critical care. I'm not sure you guys are aware of it or not, but if you do take pediatric patients, you should see some of those things which we are going to talk about. So it probably won't be that boring, even for oncologists. I have no conflict of interest, although I would like to, but none for now. And I will try to cover the basic topic of sepsis, septic shock, the current definitions which are going and what are the implications of it in pediatric oncology patients. We'll understand the basic concept of fluid resuscitation, why we do it and how much we do it. And then there is a concept of fluid overload and what are the current recommendations. So I'll start with this scenario, which should not be a rare phenomena for you guys. So you have a 10-year-old kiddo with ALL, relapsed, presented to a clinic with tachycardia, tachypnea, and fever. 2 weeks ago, he had induction therapy, and he is getting admitted for sepsis. You go to examine the patient, and you can see he is breathing with somewhat labored breathing. He is able to answer questions, but his heart rate is high, he has flushed face, and his peripheral pulses are weak. You can see from the vital signs that he is sick, and the labs below shows pancytopenia, which is not uncommon in these patients, metabolic acidosis, and his lactate, when you check it, is 3.8. So based on this, any guesses what this patient has? I know these guys, so if you picked up shock, then you're right on, which means I should probably stop talking now and move on to the next speaker. And what would you do? All right, so I think people over here, even oncologists, are very well aware of the critical care management, wouldn't do. So if you guessed that you will give fluid bolus, which is about 20 per kilo to this normal saline to this patient, send some labs, start antibiotics, and reassess your patient, that would be the right move to do. So yes, this patient is in septic shock. And so we're going to go and try to kind of see of how we define it, how we come to know at the bedside what is shock. So I know Guyton is very famous, especially for young people. I'm too old to remember, but there was a textbook called Guyton. You see this picture, Dr. Guyton from Mississippi. And he wrote this book of physiology after he developed a stroke on the left side. You can see in the picture, his left hand is sitting on his knee. But amazing guy. In his textbook, if you look at when efforts are trying to describe shock, it says shock is a circulatory disorder, means cardiovascular dysfunction. Basically, what happens is that you have low blood flow to that extent where the tissues of the body suffers. And what is the suffering? You don't get oxygen and you don't get nutrition during this time frame. Very nice and easy to understand what is shock based on this definition. The problem is, how do we bring it to the bedside? When you're standing at the bedside and there's a patient, how do you apply this definition to say this patient has shock or not? So bringing these things, we have some tools. As you guys know, this is very basic stuff. We have some clinical things which we look at. So basically heart rate changes, pulse changes, temperature changes. We look at capillary refill. We look at urine output, mental status, and try to identify if the patient is having some dysfunction. There are some hemodynamic parameters which you guys can measure, like blood pressures. And in ICU, if you have filling pressures like CVP or left-sided pressure or pulmonary artery pressures. Also some metabolic parameters. If you have labs, you have a idea of if there is acidosis and if there is lactate in there or base deficit there. There are some times we have been able to measure oxygen consumption and utilization parameter, which is more specifically mixed venous saturation. Sometimes you can check it, at least in the ICU. And then there are some newer things coming, which is the near infrared spectroscopy, which used to look at oxygenation at regional level. So we kind of try to put all of these things together and try to define if the patient is in trouble or not in trouble, AKA shock, right? So shock comes in all sorts of forms. As you can see over here, you have hypovolemic shock, cardiogenic shock, you can have obstructive shock or vasodilatory shock. Now, even though all these shocks are different of how they are originating, and I know the talk is about septic shock, but I would just like to point out that shock is associated with something we call organ dysfunction. I know you guys know that, and sorry, I'm trying to keep it simple so that we can all understand it. So the organ dysfunction is the main hallmark. So if we have multiple organ dysfunction, a patient present to us with shock, that is how we recognize it. So there have been a evolving effort going on. It started since 1992. If you guys remember, there was an international conference that happened, and societies like CCM, European Intensive Care Medicine Society, CHEST, American College of Chest, and American Thoracic Societies were the main organizations. Will build up together to come up with somehow, how do we at the bedside define sepsis, right? And you guys remember in that, this is years ago, about 30 years ago, is 1992, this paper published where they identified this definition of what is called systemic inflammatory response syndrome, or SIRS. If you guys remember, there were 4 parameters on it. You have heart rate changes or tachycardia, breathing changes or tachypnea, and then you have 2 of those, fever either or temperature abnormality, and then you had the presence of cardiovascular dysfunction in it with white cell count changes, right? So you put 2 of the 4, you say this is SIRS, and if you have a suspicion of infection, you make it sepsis. That's how it goes. We know these definitions don't have good sensitivity and specificity. So with those signs, just telling the patient has sepsis or septic shock is becoming a challenge for us to do. So there have been reiterations every 10 years or so. The societies will meet together and they will update the definition. And you guys have heard of sepsis 2 and sepsis 3. The latest iteration is sepsis 3. These are adult definitions. And what pediatric people have done is that in the middle. So when in 2001, the second guideline or the sepsis 2 came in, after that, pediatric people kind of got together and we came up with our own definitions, which is the sepsis 1, I call it. And then the last iteration, which was in 2016 for adult guidelines, which is called sepsis 3. After that, just this year, earlier in January or February, the article was published about pediatric sepsis 2, where the definitions have been modified a little bit. And the basic change is the how we define organ dysfunction. So just to kind of give you guys an idea, the organ dysfunction for sepsis purposes defined by this, what is called SOFA, right? Or sequential organ failure assessment score. Basically, this is like a tool you use, a scoring system. You look at different organ system in the body and what abnormalities they have, and then you score your patient based on the score. And I apologize about the fine print. It's probably not even clear to me right now. But basically, you calculate the score, and a certain score will tell you if your patient has sepsis or more specifically septic shock. That was an extensive scoring system, as you guys can see first. So there have been some reiterations like a quick SOFA that is called Q-SOFA, which people modify to just 3 things. You said if your heart rate is high, you have changes in mental status, and your blood pressure is low, then you have septic shock. And that's what was kind of introduced to make it easier. What we need to now know is that there is this score called Phoenix score, right? This is the newest kid in the ground. And this is based on 4-organ system, scoring system. You have respiratory system, cardiovascular, neurologic, and coagulation system abnormalities. You can score it. And based on those, you define what sepsis or septic shock is. What is important to remember is that for septic shock, you have to have cardiovascular dysfunction. So something which is cardiovascular abnormality related. I will say, though, that in oncology patients, just know that these scoring systems don't work very well. And we know this, and this study was published last year. As you guys can see, they compared several scores and tried to see if we can predict the sepsis and mortality with suspected infections. And as you can see from here, they don't perform very well. Something is different about the oncology patients, as you guys know, very well aware of. As you know, in some places, like we use early warning scoring system, and that doesn't even, our normal scoring system doesn't work very well. So for example, when I used to be in Children's Hospital Philadelphia for my cardiac stuff, they would not apply the PUs or the early warning score in oncology patients on their floor. That was not, they didn't, because they have baseline abnormalities, will make it harder to catch them. So it just doesn't perform very well. Having said that, there are efforts going on to improve it. It is very common, and to this group, I shouldn't say half of the patients that are admitted from oncology to ICU are related to 2 reasons, right? They will either have respiratory failure or shock state to present with. And if you look at what happens to them, the general mortality in these patients in ICU is around 5%. But if you look at oncology patients, the mortality extremely high. It's somewhere about 25 to 30%. In some cases, up to 35% of these patients will not survive. So something we know is not quite right. This is the data from Pakistan, from Kalab and those guys. They showed that about half of the patients who present with these things will die in Aga Khan University Hospital, published a few years ago. They also showed that if you have shock, that is associated with mortality. So shock is important. We need to deal with it. And we know that we have challenges in oncology patients. So oncology patients have worse mortality. Many, many reasons to explain it. Some of these reasons you guys already know, like immunocompromised state, you have pre-existing organ dysfunction related to cancer, you may have relapse, or you have neutropenia, which have issue. But what we are finding with the recent studies is that the delay in recognition of shock, also the therapy which you can provide immediately, delays in that, and then possibly some delays in admission to the ICU are the factors which may be contributing to some of this increased mortality in those patients. You guys know efforts are going around to early recognize sepsis. There are all sorts of campaigns over there. Surviving Sepsis campaign, as you guys know, from US is being one of big of them. And everybody's working on these things. I'm sure Shaukat Khanum Hospital has this pretty well chalked out, but this is what people are learning. We want to learn how to recognize septic and septic shock early, and these are screenings. So, in some hospitals now, everybody gets a screen maybe 2 times to 3 times a day for presence of sepsis or not. And they use early scoring system as, for that. And I explained to you guys, it may be a little bit of a challenge for oncology group here. We have also sepsis bundles. So we know also when we recognize what we need to do. And those are easily based on some steps, and I will go over it. And then we have what we call rapid response teams development, where the people can arrive at the bedside very fast and do the necessary steps to help with that. Okay, so let's move on to what can we do once you recognize septic shock. Yes, it all comes down to low blood flow, which is what we call cardiac output in ICU world. And this is very common physiology. You guys remember cardiac output is recognized by 2 different ways, right? Your heart rate times your stroke volume. And then there is a Ohm's law equation, which we use for cardiovascular system. And we say driving pressure divided by the resistance you have will determine how much the flow. The stroke volume, in turn, is dependent on end diastolic volume minus your end systolic volume during the contractility. And the end diastolic volume is related to venous return, which then in turn is dependent on intravascular volume. So you can see very quickly what we can do. When the intensivists get to a shocky patient, this is all we have to work. We have 4 things which we can do, right? Heart rate, we cannot change much, because remember, this is how we actually recognize. So when you are developing shock, the heart rate is already high on those patients, and we have lost now sort of a power to manage it. The patient is already tachycardic, and in fact, that's how we recognize the patient is in trouble. So by the time we get to them, this thing is gone already. Patient is already tachycardic. So what we can do is the number one step is give IV fluid bolus. What it does that it quickly increases your intravascular volume. That increases venous return. It increases end diastolic volume. And then if you keep everything else the same, your cardiac output will go up based on these definitions. We can also use inotropy and vasopressors as needed. And then there is this thing called lusotropy. So one of the medications which you may have heard of in cardiac population we use is called milrinone, which is a lusotropic agent. Basically, it helps relax left ventricle at the end of diastole, so more blood can be accommodated and the stroke volume goes up with that. Who remembers this curve? So if you recognize, this is Dr. Frank and Dr. Starling. So remember the Frank-Starling law, and it's very easy to understand. Now, I know that you guys don't remember this curve, but whenever you are giving a fluid bolus, this is exactly what you are doing. So you use this curve a lot in day-to-day life, but we just don't have that connection. Basically, the point here is that there is a relationship between the stroke volume and the end diastolic volume. And it says that if you stretch cardiac muscle, it will contract more. So what we do, we give a fast bolus of the fluid, which goes and it increases the size of the ventricle, which is a stretch on the heart, and now the heart will contract more. Your stroke volume will go up and immediately increase your cardiac output. So this is how the IV fluid bolus works. There are many, many questions, though, as you guys know, with the literature, which fluid to use, how much to use, and how fast you want to give it. And I'll just touch base on it. Where is this 20 per kilo coming from? I've checked Quran, is not written over there, although it would have been nice to have that answer there. But this was based out of this animal model where we developed this hemorrhagic shock model. So basically what you do is you put like an art line in an animal and you start bleeding the animal. As you take the blood volume out, you develop hypovolemic shock, right? So if you look at over here, the vital signs, as you start bleeding the animal, the heart rate first start rising up to keep up with the loss of the volume by maintaining your cardiac output. Then you have vascular resistance, which starts increasing. And it is a little bit late in the picture where you see when the cardiac output start dropping. So body tries to manage the loss of volume in certain way. What we learned with those experiments is that somewhere when you were about 20-25% of loss of intravascular volume, this is where your blood pressure started dropping. And so what happens, we recognize every time the patient is in trouble by most of the time by a drop in blood pressure. You will be checking a blood pressure will be low, and that will alarm you, right? So thinking of that, we know now that if you have hypotension, you probably are closer to about 20% loss, and hence we start the volume bolus by 20 cc's per kilo. That is the original which it came from, right? And of course, I've talked about it. You need to give it fast and it will improve the cardiac output immediately. Important to remember is timings, right? In 1990s, my mentor, Dr. Zaritsky and Joe Carcillo, they did this study in 34 kids where they have PA catheters in the ICU, which presented with shock, and they looked at what happened to them. Very interesting data. What they found out that if you received a fluid in 1 hour, fluid of less than 20 per kilo, then survival of the 14 kids only was 6. You got more fluids to about, you get more fluids to about 20 to 40 per kilo, then 4 of 11 survived. But in the group where you got more than 40 mLs per kilo, to be exact, the median was 67 mLs per kilo, was the group where there was the highest survival. 8 of the 9 survived. Interestingly, also ARDS and edema, which is the more concern when you give fluid, was less in these patients. So from that, PALS took this strategy and we said we will give 20 per kilo fluid volume, 3 boluses in the first hour, and that's where the 60 comes from. So if you guys wonder where these numbers are coming from, this is the studies which we use. Imagine 34 kids a study is what determined this strategy of us giving fluids, how we give. So, and then subsequent studies, this study used this patient we were bringing to the emergency room where they were given fluids based on the guidelines those times, the 20 per kilo fluid, 3 fluid boluses. And what they showed that if you were able to give this, you were able to reverse the shock early, and that has better survival. This is a quality control study from Texas Children's Hospital. We showed that if you change the timing to first fluid bolus to early fluid bolus, and then you're finishing 3 fluid bolus early and time to antibiotics, your mechanical ventilation days, vasoactive agents used, and the mortality was improved with that. So all was very good. We were all happy. We were giving fluids for septic shock and other stuff until this study came in. You guys know this FEAST study. This was the study from Africa, which randomized patient to fluid bolus and non-fluid bolus. There are lots of debates, and I'm pretty sure you guys are aware of that. A lot of debates of the study design and what basically malaria patients were the main population in this one. And what they showed that if you give a fluid bolus to the patient, then you worsen their mortality. Later on, dissecting this study, it turned out that it was actually the lack of a tertiary care level support that was resulting in that type of outcome. So then subsequently with that, the fluid have kind of, taken a hit, this is strategy. And in the sepsis 6 or the 6 things which you need to do, you can see the fluid bolus has dropped to like number 4 now, where we call it fluid challenge. Basically, you give a fluid bolus and look at it. And this changed. And I just want to quickly run this over with the latest guidelines of SCCM, as you guys can see over here. So there are 2 sort of categories. If you get into this scenario, you have a suspected sepsis scenario and a septic shock scenario. So remember, septic shock is the presence of cardiovascular dysfunction. And these days we define it by persistent hypotension and lactate levels together, right? So if you have septic shock, you have within 1 hour, you need to finish all of this, which includes fluid bolus. But in cases of sepsis, where you were suspicious of it, you have up to 3 hours to finish all of this. And based on that, the current guidelines are. There is another change that has happened with that. Where you are at when you are dealing with this patient now determines what you do. So basically, the FEAST study changed our thought process. And what we say now, if you work in a healthcare system where you have an ICU, then you can go ahead with fluids. If you work in a system where there is no ICU immediately available, or you don't have the ICU, then you have to be cautious about it, because that's what seems to be the problem. So the guidelines have changed a little bit, and this summary slide will tell you, basically in a healthcare system with availability of intensive care, you find a patient in shock, you do 40 to 60 mL per kilo of fluid bolus over first hour. And that's what we recommend, of course, with reassessment. In healthcare system with no availability of intensive care, that's where if you don't have hypotension, do not give any fluid boluses, and just start with maintenance fluids and follow those patients. Even in that system, if you have hypotension, you are allowed to give some fluid, although the volume which we can give has been reduced to up to about 40 per kilo. So basically 2 per kilo. And you guys can see the other strategies that we can cut the fluid boluses down to about 10 per kilo from 20 per kilo also in order to show that. When we give fluids to the critically ill patients, of course, we have this problem, which we often deal with, which appears a little bit later, right? And which is the fluid overload scenario. So we do have a patient, this problem, and it creates 2 sort of major issues for us. It developed this, what is called capillary leaks. So the fluid will leak out of the vascular system and will go into different organs, where pretty much no organ is left out when you have fluid overload. As you can see from this Michelin man, all the organ systems are a problem. The other thing is this fluid creep. So you guys know when we give a dose of antibiotics and stuff, right? To follow that, we give flushes, 5 cc's, 10 cc's here. And some of these patients are getting so many medications. People have identified that you can essentially end up giving a lot of fluid to these patients without even noting. And these things are not usually documented. And that's what have come to known as fluid creep. So we have this problem where we give a lot of fluid to our patients in that. Nonetheless, what we know so far, and this is what we know, that if you have a fluid overload of more than 10%, right, this all will then start affecting you. Your mortality will increase, length of mechanical ventilation and length of ICU stay will go up. You will have more chances of multi-organ dysfunction, acute kidney injury, and a need for CRRT or renal replacement therapy that will come into effect with. So how do we deal with it? We do need to give fluids for the shock, but then we have this problem that's going to come up. So people are coming up with this idea of EBS model, utility of EBS model into this. And you guys know the EBS model, where defined that if you have an injury, immediately after the injury, what happened, your blood flow goes down, right? You have low flow state. And then once that state is over, if you don't die, then you have a reperfusion type scenario where the blood flow starts going up. So as you resuscitate your patient, you have now a high flow problem. So the flow goes up and it goes above the normal flow. And then eventually over next few days, it kind of normalizes, it come back to the baseline. So maybe the resuscitation we need to do, or the fluids we need to give, is based on this model for that. And something which now we are using a mnemonic to use it is ROSE concept, which is that you resuscitate the patient in the first minutes to hours kind of time frame. Then you optimize the flow once the patient is resuscitated, and then you stabilize the patient and essentially take the fluid off at the end. So as an ICU, we give fluid and then we have to return it back, what's called makafate amal, right? So we have to do that. Sorry about the Urdu, but that's what essentially it is. So we are, intensivist lived a stressful life because of that. Whatever we do, then we have to return it back. And that's what we deal with. So this is your resuscitation phase 1, which is within few minutes, you identify the patient is in shock, you need to give volume. This is where early goal-directed therapy will work, right? Knowing that we will be, the target here is positive fluid balance, you give it. Optimization is that phase where the return has happened and now the patient is reperfusing. So you need to watch it. If the perfusion looks okay, then you hold off the fluids. If the perfusion is still bad and you're still in shock, then you give more fluid. Basically, concept here is to keep them neutral. And then that brings us to the next day or the 48 hours time frame where we have this stabilization. When the patient is stabilized, the flow is stabilized, and we have ischemia reperfusion issues. Over here, we try to keep them neutral, or sometimes they start negative if they can tolerate. And then the last phase, that we have to return back the favor and we have to take the fluid off by diuresing them either, or CRRT management, which is the evacuation phase in terms. So to summarize it, septic shock is common, carries a high mortality in pediatric oncology patients. Newer definitions are aimed at improving bedside utility. So we want to apply it so that you can recognize it early and do the reversal attempts faster. I would tell you this is that syndrome-based definition probably would not work. At the end, we do have to find a biomarker, something which we can check, look at the level and be able to say this is shock or not shock. We're not there yet, but we have to go there. There is a good physiologic rationale for IV fluid use, as I explained to you guys. So don't be shy about it, even though with recent studies say the evidence does support that when we use it, we need to know where we are doing this and do we have intensive care unit support or not. In the hospital with PICU, certainly allowed to give 60 per kilo within first hour, try to resuscitate as fast as you can, but you need to watch yourself for that. Fluid overload is a major concern, but there is some conceptual model which we have, which we can use to sort of figure out what we need to do for these patients. And with that, I will stop here. Thank you so much.
Thank you very much, Dr. Kram. We'll have questions in the end. Thank you for excellent talk.
Thank you very much, Dr. Kram, for such a nice talk and on a very important topic. Our next guest is Dr. Abdul Rahim. Dr. Abdul Rahim is the pediatric critical care consultant, and he has done his fellowship in pediatric critical care from Aga Khan University Hospital, Karachi. And he is associated with the Pediatric Critical Care Indus Hospital in Health Work, Karachi since 2018. Currently, he is working as a head of the Department of Pediatric Critical Care in this hospital in health work, and he has special interest in the medical education and research in the critical care medicine. Welcome, Dr. Abdul Rahim.
Thank you for the introduction, and I would like to thank everybody for inviting me. I am here with a lot of senior colleagues of mine. It's an honor for me to come and present here. A very good introduction was given by Dr. Ikram about intensive care. So with oncology, intensive care is a part and parcel. You cannot run away from us. Whatever you do, every time. And the other very big statement Dr. Ikram gave was that sepsis is a double-edged sword. I would say oncology is a double-edged sword. Every time, whatever you do with it, It has, I don't know what happened. Okay. Okay. This is from where I come, apart from Aga Khan Hospital where I worked and did my training. Indus Hospital, quite a few are aware that we are upgrading ourselves, becoming a 1800 bedded building very soon with starting next month. Yeah. We have a big oncology unit. I don't know if it is the biggest in Pakistan or not. I wouldn't comment on that, but this is where we stand. Last year we had around 1200 new registered patients. Right? Uh, a breakup of unclear slide, but a breakup of what we see. Major patients are leukemia, yes, as expected everywhere, but we have a chunk of all other malignancies that you can name. Okay. So generally, malignancy that become leukemias, brain tumors, everything that can be diagnosed in Pakistan, there's availability of those tests available. But with time, with such conferences, such meetings and advances, things are changing. The 5-year survival rate in oncology patients is changing rapidly. New therapies are coming, CAR-T, and a lot of things are coming. And with all these new modalities, with new immunosuppressions, everything, uh, the side effects are coming. Right? So it's there. And as per what I was studying to, 75% survivors face at least one major healthcare issue. Okay? And their quality of life in the long run is affected by a lot of problems. Okay? The topic that I'm presenting is neuro-oncology. See, oncology is a field with intensive care, and now they are making it more short and sweet, and with oncocritical care coming up, and then neuro-oncocritical care coming up. With recent advances, intensive care is advancing with oncology as it is, and seeing more sub and super subspecialties that are coming through. So neuro-oncology complications, they come at the time of diagnosis, they come during the treatment. Everywhere there is neurology is a component of oncology patients that we cannot run. And okay, so they are the CNS malignancies. Everybody is well aware of the CNS malignancies. They come with complications. And there are complications of those treatments that we face across. And there are systemic malignancies that have metastasized to the CNS areas of the body, like, and then they complicate. And during the course, chemotherapy is a very well-known problematic drug that we come across. Why is it important? Why are we presenting it? I hope this was the main motive. It requires immediate attention. Without immediate attention, things get delayed, things get out of hand. We need a multidisciplinary care. We need intensive care. We need oncology. We need neurology. We need surgeons everywhere, and radiology, of course. And rapid decision making is very important, because without rapid decision making, things would deteriorate fast. And then, as we say, that there is no use of treating them. Okay. One of the very emergent, very common problems that we see with, especially with the CNS tumors, is intracranial hypertension. It is a very most common, I would say, the problem that we face across. Okay. It is defined as when the intracranial pressure is around 20 to 25. Why is it important? Because it causes effect on the oxygenation of the brain. It causes cerebral metabolism effect. It causes difference and abnormality in the blood-brain barrier. Okay. What would happen then? Secondary brain injuries would occur, and this would complicate and lead to long-term consequences. Headache, first and the most common symptom that these patients have. They have blurred vision, they have confusion, they have nausea, and then so on and so forth. And if not treated appropriately and timely, they end up in loss of consciousness. How do we monitor them? If we know that the patient has intracranial hypertension, how do we do? There are some bedside modalities that we do. Pupillary size, pupillary reaction is one of them, and a very common bedside that does not require an ICU. But for other modalities, 4-score is a scoring system like GCS system that is accepted worldwide and is very commonly used nowadays, easily available. You can see the charts, you can use it bedside, and 4-score is a very important modality that is being done on bedside for all patients, not just oncology, but everywhere. And it does not give, and there is no discrepancy as in GCS that we come across, that some people measure it 6, some people measure it 7. At least 4-score is a more reliable tool that is being used worldwide. Then we go for other higher modalities that require ICU, pulse oximetry, jugular venous oximetry, brain tissue oxygenation, microdialysis, ICB monitoring, and like previously mentioned, nurse monitoring systems. These are very good monitoring system that we can do for monitoring of the ICP. How do we manage it? The management is the major part that we come across in ICU. The European Neurological Life Support, in which this is how we manage it. There's a very straightforward, simple algorithm that we follow. We have simple steps that we have to follow. Positioning, we all know these are the steps that we do, not just for hypertension, for major neurological issues. We have to ensure that the proper positioning is there. For adequate venous drainage, patient is placed adequately. We do not put the patient directly flat on, unless indicated, we place them at 30 degrees, 45 degrees for adequate venous drainage. Adequate sedation, adequate analgesia, so that nothing causes an exaggeration of their intracranial pressure. If needed, the patient is intubated, adequate, not just adequate analgesia, but adequate neuromuscular blockade also is required. Hyperventilation for a few minutes, for 10 minutes, 20 minutes is required as suggested and recommended by the European societies. Hyperosmotic therapy, mannitol, hypertonic saline, and if the things are not in control, barbiturate comas are suggested, and surgical debridement or surgical resection is the treatment depending on the source, depending on the cause. Another very important neurological emergency that we see in pediatric ICU is cerebral herniation. What it is, there's shifting of the brain tissue. How would it present? Initially, pupillary changes, if picked up early, decreased level of consciousness if picked up slightly late. But then the most common presenting time is cardiovascular compromise or cardiovascular compromise. And this is when few patients come to us, at least in the setup where we work in. How do we treat this? Steroids is the first and mainstream treatment. Depending on the cause of the herniation, depending on the type of malignancy that is present in the brain. If it is a leukemia, it is a lymphoma, giving steroids would be risky. It would cause other problem like tumor lysis syndrome. So in that situation, DEXA would be slightly contraindicated, I would say. Mannitol, hypertonic saline would be the other modalities of hyperosmotic therapy that we would do. And if tumors are not blood tumors, then surgical debulking would be the option. Okay? There are several types of cerebral herniation that we come across: intracranial, extracranial. This is how it would look like. They would bulge out, and definitely treatment would be required for them in emergent situations. This is when we come in, apart from the neurosurgeon. That is very important. Cerebral edema is a very common problem that we face. Cerebral edema would be because of the tumor itself, because of sepsis, because of meningitis, because of fits, everything that can cause cerebral edema. But in short, what is cerebral edema? Cerebral edema is when the brain volume starts to increase in size. Okay? Because of the increase in water content, increase in the electrolytes, especially sodium. What happens then is that our blood-brain barrier is very fragile. It becomes torn, it becomes there fenestrations, it increases permeability, fluid starts rushing in, brain starts to expand, and this is how we pick it up in the CT scan. This is how we used to pick it up in the CT scan. CT scan modalities are always available nowadays, but maybe years from now, CT scan modalities are many times were not available in many centers of our country. Steroids. Apparently, steroids is the major treatment that we offer to oncology. Dexamethasone, edema. If there is significant edema, there are signs of intracranial hypertension. Medical surgical management would require, and severe edema would require mannitol and hypertonic saline also, along with other measures that we had previously discussed in the European Society slide. This is a modality that we use on bedside, and I'm sure everybody uses it. ICU, anesthesia, everybody is supposedly spreading this word for past few years, how we measure ICP or cerebral edema in patients on bedside. This is called an optic nerve sheath diameter. What is an optic worksheet diameter? A lot of ICUs and even emergencies across our country even have ultrasound machines available easily on bedside. So yeah, what we do is this is a surrogate marker for assessing the intracranial pressure. So yeah, the patient is supine, maybe the patient is on intubated, maybe the patient is not in his cooperative, or with some help with the parents, we can perform this procedure. A probe of the ultrasound translinear probe is placed, and this is the image that we would get of an optic nerve. Easily available. Every physician should know how to use it. Like using ultrasounds, this is a very easily used modality and is easily available everywhere. It does not require an intensive care, can be done in emergencies, can be done in bedsides. An optic nerve sheet diameter is a very important and a surrogate marker, and is a very good tool that we can use to assess edema, to assess intracranial hypertension, and see the response to treatment. If you're giving steroids, we're giving hypertonic salines, this would be a very good marker to see importance response. So if we come down from the brain, spinal cord compressions, although a very rare entity, spinal cord tumors are a rare entity in pediatrics, I would say, but lymphomas, other tumors would be a very important part of what we treat nowadays. So they present with back pain, limb weakness, etc. A lot of general pediatric differentials would come here, with TB being a very common differential here. So a good history and a good physical examination along with a radiological test like a MRI would be a very helpful modality in this. Depending on how late and how symptomatic the patient is, the treatment is decided on those lines. Time is crucial because if the compression is significant, then it can cause lifelong issues. So if the patient has a significant neurological issue, if the patient is significantly affected by these compressions, we start steroids immediately. If we have a strong suspicion, we start steroids immediately and then go for the radiological assessment. And this can be slightly reversed if the symptoms are not life-threatening. Peripheral neuropathy. Peripheral neuropathy is a very common complications. A few of them would end up in an intensive care unit, but peripheral neuropathy with foot drop, hand drops, a lot of ataxias, diplopias would usually not end up in an intensive care unit, but some of them do. Okay? Urinary retention, hypotension, paralytic ileus, these are the things that would end up in an intensive care unit. ALL is a very common malignancy that because of the chemotherapy, this would end up. Three most commonly used chemotherapy agent that would cause peripheral neuropathy, vincristine. Not just vincristine causing peripheral neuropathy, we have seen patients of vincristine induced vocal cord paralysis. Patient would end up with stridor. Initial differential would never be a vincristine induced neuropathy. It would always be croup, will always be infection, but a vocal cord paralysis, video laryngoscopic examination or examination by an ENT physician would help us in diagnosing this and a cause of infection and a good proper history. So vincristine induced paralysis, why is it important? Because it would end up in significant respiratory distress requiring ventilation, requiring tracheostomy eventually. But the treatment is always cessation of that chemotherapy agent, and it takes around 3 weeks to a month for the symptoms to improve, and then tracheostomies can be reversed. Certain drugs like MTX and intrathecal drugs have the case reports have been done and seen which cause Cauda-Equina syndrome with paralysis of the lower limb. These are very significant neurological problems that we see in intensive care. Okay. Another wide term that I would like to use in this presentation is non-traumatic brain injury. Right? Patients with in oncology patients which are not related to the CNS tumors, they end up with acute alterations and sudden loss of GCS. Various causes are there. Okay? This requires an in-depth approach, a history, a radiological examination, and an extensive monitoring and workup system. Leukoencephalopathy, one of the very common causes of acute loss of consciousness. White matter changes occur. They are very common. Conscious level is altered. There is disorientation, there is hallucination, there is lethargy. Other symptoms would include fits, would include headache. there would be intellectual impairment. And in the long run, if this is not very severe, long-term learning disabilities, walking disabilities. A very important culprit for this leukoencephalopathy is ITMTX. ITMTX is a most commonly used drug and it causes leukoencephalopathy. This is how MRI of a leukoencephalopathy changes with significant white matter changes would look like. Chemotherapy is the culprit. So we have to hold that chemotherapy. We have to give steroids. Case reports of pulse therapy have been done and have been reported to show some impact. Oral steroids, IVIGs, other supportive therapies like multivitamin, antioxidants have been used and symptomatic treatment for the symptoms that come along. That could require ventilator, that could require long-term complication. Press is a common problem that we at least face. Major culprit is hypertension. There is focal neurological deficit, there is hemiparesis, there is fits. Diagnosis is usually made up on an MRI. CT scans are slightly suggestive, but the final diagnosis is made up on an MRI. So they have variation and wide variety of mortality rates ranging from center to center. And it is usually transient, depending on how severe it is usually transient. Antihypertensive medication, hyperedema medications are very important and they help to slow the progress of the disease and finally cause recovery. Stroke, hemorrhagic bleeds, these are common. I wouldn't go into detail because these are very common causes that we see across ICU in oncology patients, APML, drugs, whatever. They are common in monitoring and they usually require, the hemorrhagic stroke requires a neurosurgical intervention in an early phase of the treatment. Seizures, all drugs cause seizures, mostly. All diagnoses, especially brain tumors, cause seizures, especially brain tumors. Wide variety of brain tumors would cause seizures. How do we manage them? Guidelines. Each and every hospital, you name it, from US till Australia, from top to bottom, everybody has their own guidelines, but they are majorly same. You require initial lorazepam, diazepam, midazolam. You require Lirace is the most used drug that is easily available and very important. So we avoid drugs that cause hepatic metabolism because studies have shown that many of the drugs like phenytoin, phenobarb, etc., that cause hepatic metabolism changes affect the long run chemotherapy. Okay? So that is why Lirace is the drug of choice usually suggested in oncology patients. And eventually, in the long run, you require intubation, you require neurology, and so on and so forth. This slide is cerebral degeneration, a very common side effect we see. Ataxia, head nodding. This would immediately require an ICU stay, but usually not very serious to require an intubation or a mechanical ventilation. Aseptic meningitis, they present with severe headache. Aseptic meningitis, along with myelitis and myopathies, they require monitoring, painkillers to a significant effect, but they are usually not as serious like other disorders. And last, a very important complication that we come across. Right? I don't know how common it is in different centers, but studies from our hospital are coming up and soon to be published, which shows MTX methotrexate induced toxicity. I don't know how common it is, but when I was in AQU doing my fellowships and rotation residencies, MTX toxicity was not as common as it is nowadays, I presume. Neurotoxicity can occur within 21 days of MTX, which is either IT given or given intravenously, high dose MTX. There are around 7% of children and even more that face MTX toxicity. Seizures in encephalopathy are the most common signs. How do we treat it? How do we diagnose it? So anything that comes up with an history of anybody who's been given methotrexate during the 21 days of the administration, if the patient comes with any abnormal CNS finding, which is seizures, which is paresis, which is paralysis, which is encephalopathy, one of the top differentials would be MTX toxicity, but we have to rule out other causes also, like infection like leukoencephalopathy, like any other space occupying lesion, any secondary injury. Okay. These are usually transient. Diagnosis would require an MRI or a CT scan. How do we treat it? Supportive care. Single fit episodes would not require any anti-seizure medication. But if their fits are persistent and the fits are prolonged, then you would require the management of status epilepticus in these patients. CSF examination is usually not indicated unless and until you have a history of fever associated, and then your differential would definitely include other options. How do we treat them? Aminophylline is an anti-adenosine antagonist that we use in these patients given over 24 to 48 hours. Studies have proven that aminophylline does reduce the toxicity of methotrexate when used. Along with that, dextromethorphan is used. This usually comes in cough syrups, and we have used it, and they have had significant effects. Thank you.
Thank you very much, Dr. Rahim, for such a elaborated talk about the neurological aspects in the oncology patients. Our next guest is Dr. Agnes Reshki, and it's an online. Has he joined? Okay, Agnes Reshki is both pediatric oncologist as well as pediatric critical care physician at Cincinnati Children's Hospital Medical Center in Cincinnati, Ohio. She has done her training in both specialties at Stanford University, and her expertise are in pediatric onco-critical care. Her special interest is in research, focus on finding ways to improve the outcomes of critically ill oncology patients.
Hello, my name is Agnes Reshki. I'm an assistant professor at Cincinnati Children's Hospital in Cincinnati, Ohio. I'm trained in both pediatric oncology and pediatric critical care and work in both divisions at Cincinnati Children's with the focus on critical care oncology. So I really work to improve outcomes for critically ill oncology patients and find better ways to deliver care. I would like to start by thanking the conference organizers for the invitation to speak with you today. I'm sorry I'm unable to be there in person. I would have loved to have met you all. I will be talking to you today about two clinical pathways I created at my prior institution, Stanford University, to improve care for patients presenting with two common oncologic emergencies, hyperleukocytosis and anterior mediastinal masses. I have no personal or financial disclosures. Here's a brief outline of my talk. I'll first talk about our hyperleukocytosis clinical pathway, followed by our anterior mediastinal mass clinical pathways. And for both, I'll begin with a quick introduction, go through the goals of the pathway, show you the pathway focusing on the aspects I find to be the most novel and important, and ending with my conclusions. So again, I'll begin with the hyperleukocytosis pathway. This audience is likely very familiar with the phenomenon of hyperleukocytosis, but I thought this picture did a really great job demonstrating what the blood looks like in a hyperleukocytic patient and illustrating why we run into some of the problems we see. So, as we all know, hyperleukocytosis is a critical complication of leukemia, typically happening at the time of new diagnosis or relapse. It's typically defined as a white blood cell count greater than 100,000 and occurs in 10 to 20% of patients with AML and 10 to 30% of patients with ALL. The mortality of this complication continues to be unfortunately high, although it's much higher in patients with AML, which I'll explain shortly. The rates are 9 to 16% in patients with AML and 2 to 6% in patients with ALL. This mortality is due to three main reasons. The first is DIC, or disseminated intravascular coagulation, an emergency causing both hypercoagulability and bleeding, and typically occurs in patients with AML. Next is tumor lysis syndrome, which occurs when cells spontaneously lyse, releasing intracellular substances into the circulating blood, such as potassium, phosphorus, and uric acid. Lastly is leukostasis, which is sludging the blood in the microvasculature, causing obstruction and resulting in organ damage that primarily affects the lungs, kidneys, and brain. This occurs more often in AML and at a lower white count in AML due to the larger size and lack of deformability of myeloblasts, as well as interactions between the myeloblasts and endothelium. The same does not hold true for lymphoblasts, although we can still see leukostasis at a white blood cell count greater than 400,000. These complications are what we're really hoping to minimize through the creation of our clinical pathway, which advocated for quick and aggressive management of these patients. So the goals of the pathway are as follows. 1, to facilitate early multidisciplinary care for patients with hyperleukocytosis. 2, to expedite time to diagnosis and start definitive leukemia-directed therapy as soon as possible for high-risk patients. 3, to standardize our initial leukemia-directed therapy. And 4, to increase preparedness for adverse events through contingency planning and enhanced communication. This is a quick snapshot of what the pathway looks like, but I'll go through it in much more detail. The first page includes criteria for PICU admission, provides recommendations for what to do prior to admission when you get that first phone call from the emergency room or the outside hospital, and outlines what should be done upon admission. The second page goes through leukostasis risk algorithm to differentiate between patients who are known to be high risk and those who are thought to be low risk. The third page provides specific recommendations for empiric leukemia-directed therapy based on our institutional standard of practice. And the last page is primarily educational, providing definitions, describing leukostasis, and briefly touches upon leukapheresis, which is obviously very controversial, and so I will not be discussing it today. Below the images of this pathway, you'll see a citation for a paper that we published that describes these pathways, and you can find actual copies of the pathways there if you're interested in looking at it in more detail or keeping it for future reference. And you'll see this reference on all the subsequent slides as well. So the first part of the pathway is to decide which patients need to be admitted to the ICU and which patients can be managed on the acute care floor. This will obviously differ between institutions depending on the capabilities of individual institutions, but at Stanford, we admitted patients to the PICU for the following reasons. If there is any clinical concern or need for a higher level of nursing care, if the white blood cell count was greater than 200,000, if they had a concurrent mediastinal mass with airway or hemodynamic compromise, which would most often happen in patients with T-ALL, or lastly, if they had signs of leukostasis. Because our pathway relied on starting treatment as soon as possible, if the patient came from an outside hospital, we would ask that they send the patient with a blood smear so our fellows can look at it, look at the sample with pathology immediately upon arrival. We also asked for them to send a blood sample in EDTA so that it could be immediately sent off for flow cytometry. This happened in the minority of cases, but when it did, it truly expedited our management. The pathway then standardizes what labs are sent and what imaging studies are done upon admission. This includes a CBC with peripheral smear, a CMP with tumor lysis labs, an ISTAT potassium, and this was important because potassium can be artificially increased in lab values due to spontaneous lysis of the blast during transit to the lab itself. We also get a venous blood gas with lactate to assess organ perfusion, coagulation labs, a type-in screen, and flow cytometry. Then for any patients who presented with neurologic symptoms, including but not limited to headaches, dizziness, confusion, visual disturbances, or altered mental status, or if there was suspicion for AML based off of the blood smear, we would automatically obtain a head CT in order to evaluate for intracranial hemorrhage, as this would then alter our management. Then as soon as we were able to, we would have a huddle that primarily occurs between oncology and critical care, but with additional services as needed. So for example, if a patient had a mediastinal mass, then we would also include anesthesia and interventional radiology. If a patient had an intracranial hemorrhage, we would also include neurosurgery. And if a patient had DIC, then we would include hematology. Additionally, for all patients, we would implement neuroprotective measures, such as elevating the head of bed to 30 degrees and focusing on things like normotension and normonatremia. For all patients, we would also begin hyperhydration with 2 times maintenance. And then we recently added implementation of renal and cerebral NIRS, which stands for near infrared spectroscopy, to see if this could help us identify patients with leukostasis sooner before they actually became symptomatic. During the huddle, in addition to making sure that all the appropriate orders are in, we would discuss two main things. First, we would discuss whether the patient needed to begin empiric leukemia-directed therapy, and I'll discuss that in more detail on the next slide. Second, we would discuss whether patients needed any blood products. We included thresholds for transfusion and differentiated between patients with intracranial hemorrhage, DIC, or bleeding, and those without. If they had intracranial hemorrhage, DIC, or bleeding, then we would keep their platelets above 100, give them FFP if their RNR was greater than 2, and give cryoprecipitate if their fibrinogen was less than 100. We ultimately took a hemoglobin threshold out of the pathway because giving additional PRBCs increases the viscosity of blood and therefore increases the risk of leukostasis. And we were noticing that these patients were being transfused more often than they actually needed to be. Instead, now we only transfuse PRBCs if the patient demonstrates evidence of inadequate oxygen delivery, which is why we also added monitoring of blood gases with lactates and mirrors to the pathway. If a patient does not have intracranial hemorrhage, DIC, or bleeding, then the threshold to give products, as you can see, is much higher. We instead keep their platelets above 50, keep their INR less than 3. Next is the leukostasis risk stratification algorithm, which is my personal favorite part of the pathway. We divide patients into low risk and high risk. A patient is considered to be low risk if they meet all of the following criteria. If they have no evidence of leukostasis, if they're well appearing, and if morphology favors ALL or CML. On the other hand, a patient is deemed to be high risk if they have any of the following. If they have evidence of leukostasis, if they are ill appearing, or if morphology favors AML, APML, or is ambiguous. For patients who are deemed low risk, we wait for confirmation of diagnosis by flow cytometry to start chemotherapy because we know that these patients are unlikely to develop critical complications. However, if a patient is deemed high risk, and obviously a patient can change from being low risk to high risk at any moment, then we instead start chemotherapy as soon as possible with the goal to actually begin it within 6 hours of admission. Leukapheresis, as I mentioned, is a subject of a lot of controversy, but given the lack of clinical data demonstrating efficacy, Stanford would only leukapherese a patient if we were unable to initiate chemotherapy within 6 hours, or if a patient was clinically deteriorating despite initiation of chemotherapy. Our leukemia group got together, and after what seemed like a couple hundred meetings, we were able to agree upon some initial chemotherapy plans. So we came up with consensus recommendations regarding the selection of that initial chemotherapy and built out roadmaps and treatment plans into our EMR to reflect this and expedite it. To quickly go through it, if morphology was suggestive of ALL and the patient was symptomatic, we would begin either prednisone or methylprednisolone. And if the white count was not dropping despite starting steroids, they would add on vincristine as well. If morphology was suggestive of AML, then regardless of symptomatology, we would recommend initiation of cytarabine and hydroxyurea with the addition of daunorubicin if the white count was greater than 200, with a specific note to prioritize dauno over the other medications. If the patient had respiratory symptoms, which was evidence of pulmonary leukostasis, then we added on steroids as well. If the patient had concern for APML, then we would begin every patient on ATRA, and we would make a note not to perform an LP or leukapheresis, as these are both contraindicated due to the patient's risk of bleeding. If the morphology was suggestive of CML and the patient was symptomatic, then we would begin hydroxyurea. Lastly, if the morphology was ambiguous, so if we couldn't differentiate based on the smear alone, then if the patient was symptomatic, we would recommend initiation of cytarabine and either prednisone or hydroxyurea. Again, the goal here is to be more conservative and aggressive in order to avoid the development or worsening of critical complications. If the patient was not symptomatic, then we would await confirmation of diagnosis by flow cytometry. This pathway has now been live for about 3 years, and we found that this expedited interdisciplinary communication and multidisciplinary approach is really the key to improving outcomes. Having a joint discussion of the patient's clinical picture ensures that there's a shared mental model regarding the patient's risk. The multidisciplinary discussion leads to expedited consensus regarding the clinical management, and the discussion of contingency planning decreases the risk of unanticipated complications and improves outcomes. I recognize that we were very fortunate at Stanford to have the resources and support to put this pathway in place, but I hope that it may serve as an example for similar pathways that you may be able to implement at your institution in order to help manage hyperleukocytosis and therefore decrease the associated morbidity and mortality. I'll next discuss our anterior mediastinal mass clinical pathway. In the interest of time, and because this specific pathway is less novel, I'll move through it more quickly. As everyone here likely knows, anterior mediastinal masses can be incredibly frightening. They can often be missed on initial presentation, given the subtle ways that they often present. I personally initially missed a relapse of T-ALL that presented with no other symptoms other than having veins on the patient's chest that were slightly more visible. But these anterior mediastinal masses cause significant cardiopulmonary compromise that is exacerbated by general anesthesia and laying flat. Because of this, patients are at high risk of perioperative complications, and so the goal when these patients present is to diagnose the patient as quickly as possible in the least invasive manner possible. The specific goals of the pathway are as follows. 1, to again facilitate early multidisciplinary care for patients with newly diagnosed anterior mediastinal masses. 2, to increase the preparedness for adverse events through contingency planning and enhanced communication. 3, to obtain definitive diagnostic tissue in the safest way possible to expedite time to definitive diagnosis. And lastly, to begin steroids and other disease-directed therapy as soon as possible. Here you can see an overview of the pathway, and again, you can find a copy of the pathway itself in the publication that's listed. This pathway has a similar layout to the last one, although it's only 2 pages. So the first page again begins with PICU admission criteria and discusses what should be done immediately upon admission, and again features a multidisciplinary huddle. The second page includes some education and then outlines our anesthetic risk algorithm. Beginning with our PICU admission criteria, patients are admitted to the PICU if they have concern for potential airway compromise that can manifest as orthopnea, dyspnea, stridor, hoarseness, cough, wheeze, or desaturation, or if the patient has concern for hemodynamic compromise that can present with SVC syndrome, tachycardia, hypotension, syncope, or evidence of decreased end organ perfusion. In addition to the same labs we would get for a hyperleukocytosis patient, we also get a beta HCG, AFP, and ESR. We always get a 2-view chest x-ray before admission, and then upon admission, we get a CT scan of the chest if it's safe, and an echocardiogram for all patients who meet PICU admission criteria. If we're unable to get a CT of the chest in a traditional manner, but because the patient cannot lay supine, then we instead attempt to obtain it while the patient is prone, and we've actually had a fair amount of success with this strategy. We then have a multidisciplinary huddle that includes the PICU, oncology, anesthesia, interventional radiology, pediatric surgery, and our hematopathologist. Together, we all review the patient's imaging and use it to discuss our contingency planning. Ideally, if it's daytime, we try to have this huddle in person, but if this happens in the middle of the night, which it often does, then we will have the huddle over Zoom. So first we determine the patient's sedation risk category, and I'll go into that on the next slide. Then we discuss whether or not the patient is an ECMO candidate and whether we're so concerned that ECMO needs to be on standby. We then discuss whether the patient needs to be intubated, the answer to which is almost always no. We discuss whether the patient needs to begin treatment emergently before obtaining diagnostic tissue. And then we discuss how to best obtain diagnostic tissue in the safest and quickest manner possible. During the huddle, we determine whether or not the patient is a high anesthetic risk based off of either their clinical features or their imaging. They're considered high risk if they have symptoms or signs of stridor, orthopnea, wheezing, SVC obstruction, history of collapse or dizziness, and all it takes is one of these symptoms to make them high risk. They can also be categorized as high risk based off of imaging, and specifically are high risk if their tracheal cross-sectional area is less than 70%, or they have cranial or bronchial compression, if they have a high degree of SVC obstruction, if they have a pericardial effusion or tamponade physiology, if they have pulmonary artery outflow obstruction, or if they have ventricular dysfunction. And again, this is the reason that we try to get echocardiograms for all of these patients, since most of these things can be ascertained from the CT scan, but things like ventricular dysfunction, you really need an echocardiogram to figure out. For patients who are high risk, we avoid giving any sedation, and we do our best to get the biopsy with local anesthesia by itself. But if the patient is too young to tolerate local, even with distraction techniques and our child life specialists present, then this would often be an indication to have ECMO on standby. And if it's not possible to safely obtain diagnostic tissue, then we begin steroids until the patient's symptomatology improves and diagnostic tissue can be obtained safely. This pathway has been live for about 4 years now, and we have found similar outcomes to our hyperleukocytosis pathway. Again, expedited interdisciplinary communication and a multidisciplinary approach is really the key to improving outcomes. The joint review of available imaging ensures a shared mental model, and then the multidisciplinary discussion leads to expedited consensus regarding the safest way to obtain diagnostic tissue to ensure a definitive plan. Lastly, the discussion of contingency planning decreases the risk of unanticipated complications. Again, we were very lucky at Stanford to be able to create and implement a pathway like this, and I believe it's really improved our outcomes. I hope other institutions can implement similar pathways, and together we can all improve outcomes internationally for this incredibly high-risk patient population. With that, I would like to thank everyone for their time and attention, and I look forward to your questions and comments. Here is my email. Please don't hesitate to reach out with any additional thoughts or questions, and I'm happy to send out the most recent copy of these pathways if you'd be interested. Thank you again.
Thank you, everyone. We're open for questions for the panel. I would like to invite Dr. Ikram and Dr. Rahim and Agnes.
नहीं मैं बोल लूंगी थैंक यू Thank you very much to the speakers for the talk. My question is from Dr. Abdul Rahim. I have seen a couple of patients who get toxicity with the CNS toxicity with the methotrexate. We assume it is because of the methotrexate in leukemia patients because they get a lot of intrathecals. Sometimes they can have really debilitating symptoms, but the MRI findings are usually the scans that I did in a couple of patients, they were normal, but clinically they're presented with all the signs and the symptoms you mentioned. So have you seen such type of phenomena?
Thank you for this question. Yes, the amount of MTX toxicity that we see, at least 60-70% of patients would have a typical finding, but I agree with you that at least 30% would not have any significant MRI findings, and we will be treating them initially as meningitis because of fever-like symptoms, fits, because many times they are neutropenic and fever would not mount significant, and they would have a raised CRP or a procalcitonin that we do. But yes, they would be patients, and what we do is based on what our experience is that we give aminophylline to many of the patients if they have an history of MTX in the last 21 days, especially if they have been given MTX recently. We would start treating in lines of MTX toxicity first and then wait for the diagnosis to come. This is how we would proceed in an ICU, because we will not wait for the diagnosis to be confirmed. Giving aminophylline would be slightly risky. Yes, it would cause tachycardia, it would cause hypertension, and if it is pressed, maybe increase those symptoms. but giving aminophylline would be option that we opt for at least making sure that the toxicity is reversed as soon as possible.
Like, we have a couple of all these type of patients. In two of my patients, they actually got well. We challenged them with intrathecal. They again had the similar symptoms, so I had to switch them to cytarabine and hydrocodone.
Yeah, this is how we would proceed, and they have a symptom, then we would make sure that they are not given or given at a reduced dose in the next week. Thank you.
I was hoping that we get some kind of a medical management aspect as well, besides the fluid resuscitation. As you explained in last about its importance and how we have to switch from wholesale then to decreasing the fluid after 24 hours based on the hemodynamic changes which are happening in the short patient. We all, most of us are very well educated on the critical care management, and the third speaker kind of found a solution by doing both trainings. But we still face that challenge. I just wanted from this platform, wanted to highlight this issue that although 90 or almost 100% of the shock in pediatric oncology patient is septic shock, but still when these patients come to the emergency, even they come to the dedicated ICU of the oncology floor, sometimes, not always, the first drug to be started is dopamine. And we know that norepi, epi, and then phenylephrine or whatever is the, drug availability choice. So I just wanted to, make this opportunity as clarify that 99% of dopamine has no indication for, like 100% in septic shock, but most of the indications, most of the shock we see in pediatric oncology does not need dopamine. And then on top of giving a drug which has no beneficial effect, it also gives you tachycardia, which worsens are, the only shock sign which we see in pediatric population. So that was kind of a comment, but I wanted your input. Like you did mention in the chart form, but norepi, epi, and then phenylephrine, this is what our algorithm should be for the shock drugs. Is that how it should be? And I have one more question.
Thank you. I think if I understand your question correctly, this is related to the first use of dopamine as a inotrope and vasoactive agent for septic shock. So I'm happy to report that because that was my pet peeve. Actually, I was one of the people who did not believe dopamine works at all for any of these in terms of improving anything in these patients. And so my general practice is we don't use dopamine in our ICU. Dopamine is not prescribed at all. Having said that, dopamine is a medication which a lot of people are very comfortable with. And that's why you will see it in other places like emergency rooms or other places when the patients are referred to. Current guidelines, though, have taken dopamine out of the picture altogether. Basically, what we are dealing with now is epinephrine and norepinephrine as the first agents, which you do. Epinephrine is preferred in pediatric sepsis, and that's what we recommend to start using it. Dopamine, not only just the side effect you mentioned, but it has a lot of other effects which are not very suitable for dealing with sepsis patient. As you know, it has a lot of other actions on different things. So we don't use it. Epinephrine is what we need to go with. Okay, yeah, very good. The talk was not about vasoactive agents and vasopressors, but our preference now in our institution and where I was before, dopamine was not even in, even if in, yes, and it's because most of my feeling is people know how bad this medication is overall compared to the profile of other medications which we have now. Is just the comfort level with it because people used it for years and years. My seniors have used it for 30 years and they would not agree with me. You come to somebody and they have done it for 30 years with the medication, they will say, what are you talking about? I've been using it for 30 years. Not one patient has died because of it. So that becomes a little bit, but clearly now the guidelines have taken out dopamine out of the picture and majority of them now.
As far as the symptomology of shock, we, again, which we see and which we practice is like probably tachycardia is the one and the only sole sign when kids are in induction therapy of leukemia
we don't have fevers. Blood pressure again is a very late sign, and we don't go by blood pressure. Like we don't wait for that at least. So besides tachycardia, I was like we do see peripheral provision. Is that the one which cardiac, like you mentioned, cardiac, like one of the main, compromise to as a warning sign in the septic patient? So from the cardiac standpoint, basically the two things which we at the onset, like when the patient is landing in the ICU or in the ER or wherever the kid is in the septic shock, it's like your tachycardia and your vasal, like your poor perfusion.
Yes.
So those are the two main things to go for clinically. So that is.
Yes, and I think you're right on it. Like I mentioned, unfortunately, tachycardia is a mechanism to cope with the cardiac output, which is dropping. And the problem is that by the time you go and you even say, okay, the nurses will call you, or somebody will even contact me when they already see the tachycardia is already there. Then they will ask us to come. So by that time, it is already there. So we know that it's an early sign. The problem is the sensitivity and specificity of that in an oncology patient, because it's present, because as you mentioned, and a lot of other things, it becomes kind of difficult. We have to get to, come up with something which can tell us a little bit better of the shock, which we are really worried about. And that's what what causes the mortality in these patients. And like I mentioned, I think I may have mentioned that we have to get some way over this syndrome definition of combining signs and symptoms together to just a biomarker base. A lot of research is going around, and some of those have promise in defining sepsis, but actually the shock itself is the challenge. We have Procal, CRP, stuff like that people are using and try to say, do we have sepsis or not? And I think we are getting a little bit ahead now from where we used to stand before. But shock itself, we just don't have a very reliable clinical marker. Most of the people use lactate, but the lactate also, again, it's a global indicator, and it becomes very hard to do in a lot of places. But very good points. I think we were challenged with that, but I think with the time we will find some answers, hopefully, inshallah.
For the press, if we have a patient who we have documented that the cause of seizure was hypertension associated press, and our MRI is kind of agreeing with the diagnosis, and we start them on anti-epileptic. And we had this hypertension resolve over the course of maybe 1 week, and in that 1 week, the patient had 2-3 episodes of seizure and being controlled. When would you, what are the criteria to taper the anti-epileptic? Like, would we get a MRI again, and when should we get an MRI again?
So
Like weeks or...
First of all, if the patient is fit free, how we go about it, discussing with neurology, because I come from a center, we don't have a neurologist. Okay, this is a very good advantage of what we have. So we are dealing with neurology ourselves. In ICU, with oncology itself, we deal with oncology. We have discussion, we have friends who assist us all over, but we don't have a neurologist. How we go about it, if the patient is on maximum IV doses of anti-epileptics, we start tapering them at least 3 to 5 days if the patient is fit free. We try to bring them to the least possible oral dose. Right? And this is how we go about it. And by this time, most likely the patient has been shifted from an intensive care to the ward. Right? I would suggest, because press is because of a chemotherapy. Yes. Yes, he is out in that. So we would taper it down, start tapering it down, put it to a minimum. But yes, press, if it has happened again once, it can happen again. I would suggest using it for at least month or two, and then start tapering it and involve a neurologist. Yes, getting an MRI would be helpful. But tapering of anti-epileptic would be based on clinical findings, so that he does not have a breakthrough fits. And as for the previous discussion that you were having with Dr. Ikram, what we do is that we follow those patients with a Pew scoring. Yes, I know it is recommended, but not very, sometimes it is not as effective, but at least we highlight those patients with a Pew score above 4, above 6, so that we can follow them and pick up signs before they become more serious. So the Pew scoring would be helpful in at least to some extent to identify those that can develop shock Tachycardia, yes, as we were discussing, is a late sign. Other signs, irritability, poor pulses, drop in urine output, all of a sudden would be one of those markers that we would observe. Usually in oncology, I've seen patients are usually, apart from those in induction phase, are usually the most pampered of the pediatric department. I don't know why, but they are the most pampered. They have different room because of isolation or whatever. So picking those things up is slightly difficult. Okay, so they are, I don't know why they are more pampered, but they are by their physician. Yes.
I think they are more spread leukopenia, so maybe
Yes.
it's a-
Well, I'm not saying that, but they are the most pampered of the pediatric department. I don't know why. Others are usually in the ward, they have a different role. Yes.
that we-
Yes. Agreed.
That is one reason.
Yeah, I would just comment one thing here. He
Okay.
picked up a fight with the oncology guys. I don't have any problem. They are not as special. Put them in their rooms and, certainly not at all. But I was just going to mention, yes. So what we do is that we will keep them on antiepileptic medications, send them out of the ICU and forget about them. But usually the process is that they will get weaned by our neurologist service as per Caesar patients without any issues, just because of the nidus that is developed now, and it has a higher risk of recurrence on that. And yes, of course, that in turn.
I have one comment regarding the dopamine. Available drug used. Tachycardic. Acha, dopamine causes tachycardia very much. It is a rhythmogenic drug. Being a cardiologist, we do not prefer this to start in a patient with a shock. And Dr. Kram said rightly, you need a fluid. Mildenon is a fish, needs water to swim. Every inotropic drug is a fish, needs water to swim. And when there is a no fluid, how it will swim? So all the residents in the pediatric emergency working in Shaukat Khanum as well as in the children's hospital, they start with the dopamine. And even with a dose of 20 mics, so you see in the curve of the Frank-Starling curve and the other curve, the BP falls very late. The tachycardia first comes. So picking the tachycardia, poor urinary output, capillary refill gives you an idea the patient is hypovolemic. Please do start the volume. Give the volume 20 ml per kg, even 40 ml per kg. And then milrinone is a good drug. It's easily available. It does not cause tachycardia. It is not arrhythmogenic. Dopamine, dobutamine, all are arrhythmogenic. Even epinephrine, your patient is in the vasoconstriction state and you give tons and tons of the epinephrine. Norepi is in this condition is still better than the epinephrine. And regarding the neurology patients, they have bradycardia. What we have observed with the Shaukat Khanum, the patient with intracranial tumors is usually have bradycardia and long QTs. Their QTs are prolonged. You don't need to treat that bradycardia and long QT with the inotropes. What you have to do, correct the fluid electrolyte imbalance, calcium, magnesium, phosphorus, whatever the electrolytes imbalance is there, and correct the neurological disease first. And same is with the mediastinal masses. Heart is compromised. It's sitting in the center, have a little space. It is compressed. So rather asking the echo in first 10 minutes, please give the volume. Thank you.
I think we have one more question, then we're running out
No,
of
we
time.
do
as well.
all the patients with the medial sinus mass, we do the echoes, but in the first few minutes, when the patients are in the shock, you need to hydrate the patient because ejection fraction falls very late, I tell you. It's at the end point when the heart is tired of not having the volume and not giving anything outside.
Thank you very much, Dr. Tahmina. Very detailed and description of the cardiopulmonary resuscitation. Yes, we can have another question, please.
Everyone, I'm Aksa here. I'm just here to give a comment or an appreciation to Dr. Ikram and Dr. Abdurrahim. I really enjoyed your presentation and it was very knowledgeable for me. I'm just a pharmacist. You all are more educated, more honorable for me, and I just want to appreciate your efforts and your presentation. The drug related part that was also knowledgeable for me, and I just want to give you the appreciation. Thank you so much, sir.
Okay, thank you very much for a successful session and thank you very much to our guest speakers. So we're going to start the next session.
Yes, thank you very much. So we will start session number 3. The chairs for the sessions are Dr. Zahra Fadou. She is a professor of pediatric oncology and the chair of the Department of Oncology at Aga Khan Hospital. And Dr. Irfana Ishaq Sindhu. She's a consultant pediatric oncologist at Shaukat Khanum Hospital.